You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everybody, and welcome to Just Medicine. In this podcast, UBC medical students get together to talk about equity and its place in our healthcare system. My name is Sebastian Lopez Steven, and I am a second-year medical student here at the Vancouver Fraser Medical Program at the University of British Columbia. This is a second episode in our two-part series that focuses on the health of migrant farm workers. We bring to you today a conversation with a family physician who works in the Lower Mainland, providing care both at outreach fairs in the Lower Mainland and in the clinic. If you refer to our previous episode, you'll get a really good background on who migrant farm workers are in Canada and why their health is being affected by multiple social determinants of health within the nation, including immigration policy and issues with being able to deliver care to these individuals where they are, especially in the face of oppression within the workforce. What this conversation really expands on is the idea of having to learn continuously how to provide care for a population that has very unique needs. I'll tell you why this is something that's really close to my heart, because I, for the last 2 years, have headed a program out of the University of British Columbia's bike shop called the Bike Kitchen. In this program, we focus on providing bicycles to migrant farm workers that exist within the Lower Mainland so that these individuals can leave the farms in which they are employed and actually engage in Canadian communities and be able to buy their own foods and, importantly, get to their own healthcare appointments. Something that really rattled me the first time that I got involved in this type of work was when I found out that a lot of migrant farm workers are entitled by immigration law to be terminated from their jobs simply because they reveal that they might have healthcare concerns to their employers. When they get terminated, there's no ability for the migrant farm workers to push back on the reason that they get terminated or their employment gets terminated. And so these individuals are really working hard to try to make money to send back to their families in a variety of Latin American countries. And they also have to hide a lot of their health issues from their employers because otherwise the employer might hear about any healthcare concerns they might have and then terminate their employment, which leaves them in an obviously very precarious position of not only being able to not bring in income for a family that really requires it back home, but it also runs concerns for this individual who now is not able to seek care for ongoing issues that can cause them their own distress. And they can exist undocumented in Canada for a certain amount of time, which comes with its own health equity issues and adverse health outcomes. And so I think what you'll find from the conversation today is really hearing how a family doctor can make adjustments to the way in which they're delivering care to meet the unique needs of this population. And I found it very interesting to speak with this individual because I actually have been engaged in some of the health fairs that this individual speaks about going and providing care. And I've come at it from a bike mechanic perspective, and it is really incredible to me how similar these experiences are. So for context, these health fairs usually happen about once a month, or at least those are the ones that I've been involved in. And a lot of the times they're headed out of churches that exist in the Lower Mainland, in Delta or Abbotsford, because a lot of the times these migrant farm workers are from Latin American countries, and Latin American countries have very deep, very rich histories of religiosity that combines with their way of living. And so when these health fairs are headed out of churches, you've immediately created a community feeling that brings a lot of people together that are coming from the same backgrounds. These health fairs are meant so that when all the migrant farm workers are brought in by NGOs that exist in the community, they are brought in to discuss issues that relate to the opioid crisis. So for example, they've been trained on naloxone when they come to these fairs. They're provided cultural food so they can all get together and relax after some hard work that exists on the farm. And they're also trained in public health issues, their rights as workers on the farms. And during this time, they can get picked out one by one if they wish to be seen by a physician or by a nurse to provide them care. And what's great about this way of providing care in the community for migrant farm workers is that the employers, as far as they know, and as far as they can really know, these migrant farm workers are just going and enjoying time together, which in and of itself is a good thing for health. But what it also allows for is for these individuals to engage with healthcare services without having to reveal to their employers that they are engaging with healthcare services and do have ongoing healthcare concerns that might put them at risk of termination of their contracts. My role there is to fix their bikes. And the reality is that it sounds like a simple task, but it really hit home how valuable these bikes are to these individuals, because the bicycles allow them to get off of the farms where they're living under the system that we have as migrant farm workers. And it also allows them to engage with healthcare services without having to reveal to their employer that that is what they are traveling off-site in order to do. Because otherwise they would have to ask the employer for transportation to a healthcare appointment, and that comes with the risk of outing themselves. So when these individuals come to the healthcare fairs, a lot of the times they come with their bicycles and they give them off to our booth, who can then work on their bike for the next 6 hours, 5 hours, whatever, and try to fix the brakes, try to fix the gears, put them back in a position in which these bicycles can continue to be a lifeline for these individuals. And it's so interesting because a lot of the times when they come, at least in my first year, when we were getting these bicycles together, they were really coming in just terrible state. Like every issue you can think of in these bicycles, they've got. The tires are off, the brakes are not able to grab anything, the gears aren't changing. Sometimes the handlebars are loose to the point where they're just holding onto the stem, trying to keep it going. But at the same time, they need these bicycles. And so they are riding these things out until they become obsolete. And when they become obsolete, they're going to be in a very vulnerable position. So in my first year, these bikes would show up at our booth, and we just kind of worked on whatever we could in that amount of time. And we'd usually pump out 30 bikes, 40 bikes over the 6 or 7 hours that we were at these fairs. And this is myself and a team of other mechanics. And what I found super interesting was that we'd send them back, but we never really knew if the repairs that we made to these bicycles were the repairs that were asked for by these farm workers, because we as mechanics only just know that when we see gears that don't work, we'll fix the gears. And the next year, I kind of put a little bit more thought into how I was working with these bicycles when they showed up. And what I realized is that it's, especially after 1 year of being in medical school and then coming back to this, it was really interesting to find out that really there was value in speaking to the migrant farm workers that did come to the booth to drop off their bike, and just found out what is their biggest concern with this bicycle. If they were okay with the fact that the gears didn't work, but they needed the brakes fixed and we didn't have time to do both, then that was our answer, was we had to fix the brakes. In the same way that when somebody comes to the office and we're looking through their charts and realizing there's a lot of comorbidities here, there's a lot of issues that are coming together and contributing to this person's healthcare picture, the reality is that you really can't take care of it all in one go most of the time. And it's valuable to have a conversation with the patient, or in this case, with the migrant farm worker, and just figure out what is their need, what is their most important ask. So this conversation, I think, is really reflective of experiences that I've had more on the bicycle mechanic side, and now experiences that I think I might have in the future as a physician, that seem to manifest when speaking with this family physician about how they're able to provide care in a culturally competent manner. And when we talk about cultural competency, what we're talking about is providing care in a culturally acceptable way so that individuals feel safe when they're receiving care and it's in line with their own values. And when we are talking about cultural competency, a lot of the times these considerations really focus on somebody's true religion cultural background or geographical cultural background, which in and of itself are considerations that should always be made with cultural competency. I think an added layer that can go onto this is that we can really expand the definition of cultural competency to think about cultures that are just more about an individual's life experience. So an occupational culture, for example. This conversation today focuses on repetitive work injuries that exist a lot of the times for migrant farm workers because they're doing repetitive movements because they exist in an occupational culture that is asking them for that. And so when we're giving cultural competent care and we're giving MSK care, we're giving care that is specific to their own repetitive use injuries, while also being considered to the fact that these are migrant farm workers that are newcomers to Canada and have their own culture in that aspect. So we get back to a lot of intersectionality talk, I think, when it comes to these cultures and how to provide care in that meaningful way. Another example of cultural competency that I think is important to highlight before we get into this conversation is that we talk a lot about cultural brokers in this conversation. And this was covered a little bit in the previous episode, but in this episode it really becomes clear that there is a specific culture in which physicians are providing care to migrant farm workers, and these migrant farm workers come from systems and environments and families that are very different from what we have in Canada, which is a perfectly acceptable thing and is a consideration that always should be made for any patient that comes through. But what's very interesting in this conversation is that a lot of the times those that are providing the care, because we just don't really have the type of demographics that match those migrant farm workers that are coming in, the use of cultural brokers is super important. And I myself, as a Latino person, can kind of understand what these individuals are bringing to the table in terms of their expectations of a healthcare system or their considerations from back home and what their priorities are in terms of their health. But for other individuals who don't come from a Latin American background or any specific background of the person they're speaking with, it can always be valuable to have a cultural care broker, which are individuals that know both systems and have understood and spent time with the idea of synthesizing where both systems can exist and are at odds with each other, and then describing that both to the patient and to the provider so that you can provide more specific care to these individuals that gets the health outcomes that you're looking for. And I think this goes back to that the cultural care brokers have so much value and can be a resource that can be applied really to any type of healthcare system or healthcare environment, because these are individuals that are able to better bridge the gap between patients and providers. The concern, obviously, is that these cultural care brokers can't exist all the time, or at least in the system that we have now, they can't exist all the time. So what's nice about this conversation is that there is an acknowledgement of the fact that cultural care brokers are an invaluable tool, while also acknowledging that you as a healthcare provider, when faced with patients that are coming from a very different position from you or have come from a very different background from you, can make changes in order to better understand what's going on in front of you and then modify the way in which you are providing care to best reach these individuals and focus on their own barriers. So in this conversation, what I would really encourage the listener to do is to be open-minded about the way in which their future practice or their current practice could change based on what patients are asking of them. Which ways can you deliver care that is more specific to the patient population that you're working with? And how does that mode of delivery change the way in which you can positively affect health outcomes? If you're looking for more background on migrant farm workers as a concept, I think the first episode is a better place to start, and you'll be able to hear a lot more about what the immigration policy is for these individuals and how there is a system in which these individuals exist in that is inherently discriminatory and marginalizing. And then once you've had that listening and that understanding of what's going on there, you can come into this conversation and use that as your groundwork for a conversation in which we talk about migrant farm workers and we give them the advocacy that we need, while also really taking a lot of lessons from providing care for migrant farm workers and getting those to expand into culturally safe care provision. There are some resources that exist here in the show description, which I think would be really valuable for any listener that would be interested in hearing about them. especially those that are looking for change in healthcare systems in general and wanting to do more advocacy work on a larger scale. So today I'd like to introduce to you Dr. Mary Kozial, who is a family physician who works at the Umbrella Clinic, which is one of the outreach services that really focuses on migrant farm worker care here in the Lower Mainland. You can sit back, you can relax, and really appreciate the amount of knowledge that Dr. Kozial brings to the table when it comes to providing culturally competent care for migrant farm workers and for all patients in general. And I would really challenge the reader to think about what lessons from this conversation they can bring into their own practice about how to provide care for their unique populations that they serve. All right. Well, thanks so much for joining us, Mary. It means a lot for you to be on the show with us. I'm wondering if you could introduce yourself to the viewers and kind of speak about your role and how you got involved in this.
Yeah, absolutely. My name's Mary Kozial. I'm a family doctor who also does emergency medicine. My background is actually in Indigenous health. So I did the Indigenous Site Family Practice program at UBC, and I have a part-time family practice in the communities of Takla and Yukutje First Nations. And so that's my main gig. I do some urban emergency work in Langley. And just over the last couple of months, I started working with the Umbrella Co-op Multicultural Clinic. And that work stemmed from some work I used to do at the Urgent Care Center at Reach on Commercial Drive that introduced me to just how many people in the community don't have MSP and are struggling to get healthcare. And then from that work, I learned about what Umbrella was doing and was very excited to be able to participate in that, partially because their model is so comprehensive in terms of delivering care that you really need multiple people as part of an interdisciplinary team and not just a one-off urgent care clinic visit. So that is how I got connected to Umbrella and have been working with them for the last few months.
That sounds really cool. And it sounds like there's a nice kind of shift in the way that we're giving medicine to individuals that really need it. When you're talking about kind of what you do with these migrant farm workers, what kind of clinical interventions have you done so far? What kind of strategies have you used to reach them?
So I work with the mobile clinic. So it's typically around once a month, and we hold it out of a church in Langley. So they have a big gathering, a bunch of volunteers cook dinner, and then I run a clinic. And just this past time, we were able to get a physiotherapist to come out as well. So people are able to come see me. They were able to see the nurse and able to see the physiotherapist as well. So that was really nice because I think people have such limited time off that making it, really worthwhile for them, I think is important. They got vaccines at the last clinic as well. And I think that that's, when we're thinking about how to deliver care, I think that's an important part of it is just recognizing, what people's limitations are and working to meet them where they can.
For sure. And it sounds like it's really nice that you're able to kind of go into the community and do it where these individuals are comfortable. When we're kind of speaking about the unique population that you're working with in these outreach clinics, what sort of challenges are you seeing? I know you said you were kind of new to it, but what kind of challenges have you kind of seen showing up, and how have you been able to kind of mitigate those?
Certainly access to physiotherapy was a big challenge that I think that we've made some progress on because so many injuries are repetitive overuse injuries from employers just not being very thoughtful or cognizant or just caring about the kinds of stress they're putting on their employees. So we see a lot of people who are coming in with, like a decurvains, tenosynovitis, which, I think is preventable if you think about the ergonomics of the work. So being able to provide physiotherapy has been really helpful because, accessing it both from a cost and again, from a logistics standpoint, is really challenging for people, and they often need ongoing care, not just a one-off me showing them how to do some exercises. Another thing that's been tricky is referring patients to specialists. So a lot of the farm workers have this private insurance, which is different from MSP. And it's been really challenging to get specialists to accept it, even though they get paid better with this private insurance. I think it's often just like an unwillingness to take the time to figure out how to set that up. And there's even been some issues with, not like certain specialists not being willing to see patients because they don't have a functional level of English, which I think is something that's the onus is on us as physicians. We have access to a free telephone language translation as physicians. So I don't think that should be a barrier for people accessing care.
Well, it's super interesting to hear that there's a little bit of difference in the insurance. Maybe for the listeners that are not super aware of this and to maybe to your knowledge as well. When you say private insurance, is that something that's provided to these migrant farm workers when they come into Canada by some other body, or is it something that's coming from home?
Oh, good question. So it's through their employer. Every employer is supposed to provide their employees with insurance. That is not always the case. There's definitely some people who are either not provided it or provided so little education around what it is and how to use it. So that has been one really nice thing about working with Umbrella is the staff there really understand these different forms of insurance and how to work with them. Whereas when I was working at Reach, the urgent care center, we get lots and lots of people who come there specifically because they know that we're willing to see people who don't have health insurance. But then it can be really tricky for things like labs and imaging because we don't have any specialists on our team who know how to navigate their insurance programs.
Interesting. Okay. And when it comes to that insurance being tied to their employment, do you ever find that a lot of these workers have concerns about the fact that if they're fired or terminated from their jobs, that they might lose some health insurance?
Definitely. And people are worried about that. People are worried whenever I recommend that they should take some time off so they're able to recover whatever work. It's an injury that was created by the workplace, but they're often really trepidatious about taking the time off that they need because they can be punished for it by their workplace.
Now, it sounds so tough to be in that kind of middle ground of making sure that you're completing whatever work you need to be able to bring in a good income, but at the same time taking care of yourself. And that sounds like a bit of a challenge. When it comes to kind of ways that you've had to adapt your practice more in that individual clinical setting, what types of strategies have you used to really help with providing medicine in a more culturally competent way or more getting to the root of their issues?
One thing that's really lovely about working with Umbrella is they have cultural translators. So they're not just providing translation between Spanish and English, but they're also providing a lot of context. And that's been really nice because they are also excellent advocates and understand a lot of these workplaces. So there's been a couple of times when Kozial, for example, has said to me like, oh, I know that they work at so-and-so company and they have had this problem before. Do you think you could provide a letter to the company to make sure that this gets set up? Or do you think that you could advocate for reduced hours and specifically ask for this? So that is such an asset because there's so many things like that I'm not aware of. So having an organization that has that expertise makes such a big difference. I also think finding written resources and finding stuff specifically that's in Spanish is very, very helpful. So people have something to take away with them because there's often, a lot of information shoved into a small encounter. And then there's just, the challenges of people having received care in a different country. So some of the medications that they're on, I'm not very familiar with, trying to figure out if this thing is the same thing as, what I call perindopril, for example. So that can be a little bit tricky to navigate as well. And sometimes pharmacists can be really helpful in navigating that.
Yeah, it's super interesting that you're able to have that kind of intercollaborative approach. And I really resonate with what you're talking about when it comes to the differences in cultural experiences. My mom was trained as a physician in Mexico and then came here and kind of had to make that big switch. And what we really changed was that the way that we structure the healthcare system really comes and comes to a full circle when you're speaking to the patient, because a lot of these Spanish speaking patients that I've seen maybe through family practice expect a different way of being cared for, a different way of being referred than a lot of what the Canadians have really come to terms with. So it's super interesting to hear that comes up. I had a question. I know you were speaking a lot about doing a little bit of advocacy work that kind of falls outside of what we as trainees kind of perceive as a medical doctor. What do you think has been a help for you as you've trained for getting to that type of stage? Have there been any kind of training in your residency or in your medical school about how to do advocacy work that goes beyond just kind of prescription work and writing up tests and imaging and interpreting them?
That's a good question. I think I was very lucky in that I did my residency with the Indigenous site, and a lot of the emphasis on that program is providing culturally safe care and recognizing that so much of that goes beyond medicine. It's about like how you relate to the person, how you build trust, how you build that relationship. So that my program focused on that through things like our academic days. We would often spend in different Indigenous communities. We'd have elders be part of our days, and they would lead sharing circles and ceremony. So that was really impactful on me in terms of how I think about medicine. And I think that similar principles apply in all areas. It's just, family medicine in particular is based on building relationships. And I think that sometimes gets lost in medical training. I know that there's a bit of a hidden curriculum in medical school, and it's certainly not how to be the best advocate. So I think that stands out as the most impactful thing for me. I think there was, there's increased training. I went to medical school at McGill, and there's increased training and education now about public health and about social determinants of health. And that I think is helpful. In a lot of ways, it doesn't always go far enough. And sometimes there's a lot of resistance from trainees to learning about these things. But I do think that it's important that we're seeing that shift, which I think even 10 years ago, there was quite a difference.
Yeah, it's really reassuring to hear that this type of work and this way of approaching medicine is kind of coming into the periphery, if not into the central part of it, because I think that as much as we're told in class, okay, when this organ goes awry, this is what happens. But the reality is a lot of these health issues don't really happen in a vacuum. So, to just tell us that you have to intervene at this point when all of these different issues have kind of created this is tough to hear and a tough thing to balance. So I'm glad to hear that you had a good experience and that you've been able to put it into practice.
I was just going to say, I don't know that much about this, but the Royal College has recently put forward some sort of mission statement that they are going to be centering concepts of anti-oppression and anti-racism in their curriculum. And the reason I know about it is because there's an American lobby group that is lobbying against this, saying that they're very concerned that we're going to be learning about racism as opposed to like actual medicine.
Oh,
So that is a little bit disturbing. And, whenever there's like movement, there's always a lot of pushback. But I think that the Royal College is having these conversations is a very good, is very reassuring.
yeah, for sure. Even if there's a little bit of pushback, it's nice that there's still kind of at least a desire to want to keep moving forward. So that's a positive. It's something that we'll keep an eye on for sure. There's a lot of resources that are going to be inside of this episode description, and hopefully we can find something to put in there so that readers would be interested in taking a look at that. I've got some questions about kind of your own experience when you provide this type of healthcare. We talked a little bit about your background and how you've been trained before, and I was wondering what type of impact your own identity or your own cultural background might have on the work that you've done to provide healthcare for migrant farm workers.
Yeah, it's a good question. I'm a white settler, so I don't have background as an Indigenous person or as a Latino person. So I think that probably some of my impetus for this work is just the responsibilities I have as a white settler to, serve communities from whose exploitation I have and continue to benefit from. And I think that that applies to all communities that experience marginalization, that, the systems that put that in place are things that I benefit from as a white settler. So hopefully the work that I do in some way acknowledges that.
That's a really good attitude. And I think that makes a lot of sense when you're trying to find that balance between working with your own identity and really putting into cultural, right, into clinical practice like that. So I totally understand where you're coming from. When it comes to the migrant farm workers and what you've sort of experienced so far, and I know you said you're kind of new to it, but what kind of outstanding needs do you think really need to be addressed from a health equity point of view? Like, what has kind of come up in your clinical experience, or maybe just in chatting with these individuals, that you think that we as physicians could really help to try to address?
I definitely think access to care for chronic health issues is important. I think that that's better done at Umbrella, but in the other setting that I have seen migrant farm workers in the emergency room or in urgent care clinics, that's really obviously a gap, that we're not providing good preventative healthcare for migrant farm workers, and as well people working like construction and other areas. I think from an advocacy standpoint, this is more as, physicians and citizens, is pushing for policies that hold businesses responsible for their employees, and making sure that they offer reasonable housing and reasonable compensation, and things like ergonomic considerations in terms of maybe rotating tasks so people aren't developing these overuse injuries, allowing for days off so people can get to appointments if they need to. I'm thinking of a patient who I saw who's developed sort of a chronic persistent injury secondary to her farm work, and it's made her unable to work to earn the kind of income that she needs to send back to her family. She's supporting quite a few children back in her home country, and she's gotten like a very small payout from WorkSafe for it, but otherwise that's it, and she's really not able to do the work that she used to be able to do. And so it puts her in this really difficult position where she can't really sustain herself or support her family. So I think things like that are preventable. Like we need to think about ways to prevent people getting to that point of injury where they really don't have any other options. This sort of ties back into what I was saying about physiotherapy, but I think more education in general around ergonomics and like things people can do to stay safe at work, things like postural things. If you're doing this kind of work, like what are some exercises you should be doing on an ongoing basis to prevent injuries? I think that is really not offered, and not something that I personally know a lot about. I think it's tricky, both in family medicine and emergency medicine. There's certain things that we're taught to diagnose and treat, but it's quite small compared to somebody who specializes in physical therapy. And so I think trying to have the skills and knowledge to help with that. One thing I started doing as part of my work in Indigenous communities is myoactivation. I'm not sure if you've heard about that.
I recognize the term and I can probably piece it together, but maybe we can explain it for the listeners just to make sure that we have it all there.
Yeah, so it's a system that was developed by Dr. Greg Siren, who is based out of BC, and it's essentially using needles to release fascial planes. And so it's based on this like series of movements that helps you identify where people have fascial thickening and fascial scars and fascial tightening, and then based on people's movement patterns, using needles to release certain points. It's very good for treating chronic pain. So that's something that I picked up on because of working in communities where there's a lot of chronic pain, chronic trauma, and then had colleagues who were doing it. And so I learned about doing it myself. And I think it's growing. There's more and more people who are learning it, but I think it's still a little bit fringe to have these skills that seem a little bit outside of the scope of family medicine. But I think has made a big difference, both in terms of the care I can offer for my patients who have chronic pain, and then also in terms of work satisfaction as well. Because I think if you actually have something to offer besides, negotiating pain medications, it makes your work a lot more satisfying.
Yeah, that's super interesting. If a trainee was listening to this right now, like where would they be able to learn something like that? Or like how does that kind of continuing education come up for you?
So they offer courses, and I find I think there's 4 levels of courses, and I've done the first 2. And I think even with the first level of training, you're able to treat, I would say, a good 80% of the things that you see come into your practice. So if you look up Myoactivation, BC, then you can find some resources as well as some links on how to take those courses.
That's super interesting. And it's really good to hear that there's like at least resources that somebody who is kind of navigating into a new space could really try to find if they're trying to provide culturally competent care or just helping anybody who can really get over that. I guess I just in clarification, like what kinds of reactions have you gotten from patients when you are coming up with, I don't want to say like new ideas, but new treatments that they maybe have never been exposed to before because of their culture, or what kind of experience has that been like?
Yeah, I find people are sometimes surprisingly receptive, especially when you talk about needles, because a lot of people have needle phobia. In like the migrant farm worker population in particular, I find people are very receptive because they're really keen to do anything that's going to help with their pain. I think that I use it in all the various settings that I work, and sometimes there's a little bit of uncertainty, but usually I try and start with something really, really small. And then once they see that there's an improvement from it, then that again helps build that trust that I'm doing something grounded in theory and not witchcraft.
Fair enough. That sounds really nice that you're able to give a bit of like a lifeline in some ways, because I think what we're from a trainee's perspective for me, I think when we're going through family practice, and a lot of the times we have individuals who come and they say, we've tried this and this, like, okay, we'll just refer you and we'll just wait. And people get stuck in this middle ground of just waiting for the next option. And I think it's really nice that you can provide this type of care, and especially in the population like these migrant farm workers that really need it when we're getting towards the end of the options.
Yeah, and that's something that I think for anyone who goes through a rural family medicine training program, that is something that I've learned. The communities I work in, Takla and Yakutia, they're very remote. Takla, the nearest community with a pharmacy and an X-ray machine and some blood work, is 3 hours down a logging road. So you sort of learn that the more that you can bring to the table, the better. Because if you don't learn these skills and treatments, it's possible somebody's never going to get access to them. So it's puts some impetus on you to like continue with continuing education and constantly be trying to expand your skill set, which I think is rewarding as well, because you're not, like you said, just referring people on, you're learning how to do more and more yourself.
Yeah, that's great to be able to take a bit more responsibility, but also understand where you kind of lie in this system. When you're kind of speaking about challenges that come from rural areas, and from what I've understood, migrant farm workers come from a while away to be able to access these types of clinics. How long are the appointments that you are able to set up with these individuals? Like, how long do those appointments go for, and kind of what type of process would we look for when these individuals are really not accessible except for when they're in your office there?
Yeah, that's a good point, and I think that would be a barrier in a lot of settings. So with Umbrella, we typically get 15 to 30 minutes. I think they usually book the appointments for 30 minutes, which is really essential because the translation takes quite a bit of time. And I think that that's so important in terms of providing quality care. And in the current system, and things are sort of changing in BC in terms of how we fund family medicine. But I think in some settings, family doctors and specialists are often fee for service. And so the time that you need to do something properly, sometimes people feel like they don't have it because they're expected to see people in 5 or 10 minutes, and that's just really not realistic. I think, but it's again similar to the work that I do in remote Indigenous communities, it's salaried work because in order to do it properly, it takes time. And I think that that's an important thing for providing this type of care, is having a payment model that reflects the complexity of the patient population and affords the time you need to do it properly.
I think that really resonates with me because a lot of this shadowing that I've done in those types of settings where we're booking people for 30 minutes or 40 minutes or whatever, and physicians are being paid on salary, like we've gotten so much done in that time just because there's been no kind of, okay, here's your one requisition, like see you in 3 weeks and we'll deal with it then. And it's seems like it's better for patient safety. It seems like it's better for patient satisfaction and work satisfaction. So I think if we can move towards that type of model, it'd be ideal.
Yeah, I had a friend who did some work at a newcomer and refugee clinic, and it was free for service. And she said it was just completely non-functional.
It's too bad to hear.
Mhm.
Well, hopefully with some changes that are coming to BC, then maybe we can kind of get towards that. But it's interesting to kind of hear about how much of a back and forth there is across the board. When it comes to, I know you're talking about resources written in Spanish and kind of language being a big, I don't want to say concern, but at least a theme that has kind of come up. Have there been any resources that you can access to be able to learn some Spanish for the clinic? Or how can you, I know that you have those cultural translators and those individuals obviously have a lot of knowledge, but have there been resources for you to maybe try to be able to bridge that gap, or what types of ways can you explore that?
Yeah, because I think that learning Spanish makes the work more enjoyable too, even if you're able to explain, share a couple of things in Spanish, it just helps build that connection. So personally, I took Spanish classes at Hola, Spanish classes on Broadway. So it's a Spanish language learning center. They offer evening classes, they offer some intensives. So I was able to do it for 4 days a week. So that was really nice and rewarding. And I think the nice thing about my current schedule is it's very self-built. And so that I was able to take some time off and take Spanish classes, and that was really fun. Um, I know that at Reach, because they have such a large Spanish-speaking population, they have started some informal medical Spanish learning classes where they just get together and practice speaking or practice doing patient interviews together in Spanish. Um, so that I think that that's an example of something that's, grassroots that they try and start up to um, again, make the work more enjoyable for themselves as well. But there's not, I went to medical school in Montreal, and we had um, French medical classes available. And there's nothing like that, despite, I think, Spanish being a very useful language in BC. There's nothing that I could find that wasn't an online course about medical Spanish. And I think that that would be an amazing resource if that were to be available.
That's super interesting to hear. And I think I really admire that there's a lot of, it's very clear from this type of conversation that the theme with your practice and what's come from your work with the migrant farm workers has been a lot of identifying a community level issue and then kind of taking steps as a physician to be able to learn how to change your own practice or modify your own way of doing it in order to provide the best care. It sounds like that's a lesson that a lot of trainees or learners that are listening to this could really take away.
Yeah, that's a great point. I think that it really enriches your practice and your life to do those things as well.
Yeah, for sure. So it sounds like we've got some, hopefully there's some learners on this or some trainees who might be interested in kind of taking that up, and hopefully some practicing individuals as well who might want to change a little bit of their ways. So that sounds really awesome that you're kind of setting the example there. I know we're kind of getting towards the end of the conversation here, so I don't want to keep you too much from your very exciting admin work that you said you were doing beforehand. But when it comes to kind of like a bit of a wrap up to all this, when we're talking about what learners or like practicing physicians could do when they encounter migrant farm workers, maybe in other settings, what types of advice or tips do you think you would give to individuals to really be able to help promote health equity when those individuals come across their clinical space?
I think a really important one that seems very simple but I see it bypassed so often, is to get translation. I see so often, because people feel rushed for time, that they have these medical encounters with somebody who has very, very limited understanding and ability to express themselves, and we just go based off of that conversation. So I think advocating to get, whether it's a phone translator, or some of the hospitals have these iPads where you can have somebody there for a video translation. So that is important. You will also see very often people have family members translating for them. And again, depending on their relationship with the person, that might be inappropriate. So just trying to take the extra time to translate properly, I think, is an important piece. Another important piece is trying to understand what type of insurance the person is working with and gearing your advice and your suggestions towards that. So if they have medication coverage, if they have something that will cover physiotherapy, that makes a really big difference. At Reach, we often have patients who don't have coverage for any labs, any imaging. And so you learn to just really think about, like, what is completely essential here and what can I not order this time because the cost would just be too onerous. And then what a friend of mine, Kelly Lau, what she has done, she's a family physician who works at Reach. She has started up a resource document. These are places where these are specialists who will see people who don't have MSP. This is lab work that you can get done. So for example, you can get free chlamydia and gonorrhea tests if you send it to BCCDC instead of sending it to Life Labs. So collecting that sort of information and making sure that you share that with the staff. I think that kind of advocacy work is really, really important. Using pictures, I think that this is, it probably should be something we're doing with all patients, but I think we often talk so much, and even if we're using fairly accessible language, we're talking about concepts that people just aren't that familiar with. And so I think if you bring out pictures and you point to things and you explain it as you're going, that is so much more valuable to somebody than if you just explain something in words. It's a lot more difficult to understand. So I think that taking the time and then clarifying people's understanding as well is really important. The other day when I was working at Umbrella, I had a patient who had been seen at Langley Emergency Room, which is where I work, with Bell's palsy. And then he came to my clinic because he still really wasn't sure what was going on and he thought maybe he had a stroke. And so I think that there was a lack of clarification of his understanding from that encounter. And so I think that taking the time to understand what your patient understands is very important, especially when there's language and cultural barriers.
These are all really great tips and I really appreciate that. I think it's super interesting to see kind of what we were talking about with the theme before of collecting all the information and all the resources about what's available for somebody's coverage and doing a bit of a grassroots approach to, okay, all my colleagues here, if it's to your interest, which is so funny because it sounds exactly like what we as learners do when we make notes about whatever theme we're doing with, oh, I made this graphic, I think you guys might like it, here you go. Like, it sounds like it's something that can be done on a larger scale to try to keep equity up in the future when you're a practicing physician. So kind of good to know that we as learners are at least getting towards that. I find it super interesting when you're talking about using pictures to help explain concepts, because I think that, we were talking about getting translators and understanding that you have a different cultural background, but it's nice to know that you're not kind of stuck between either you only speak to them through the translator or you do nothing, right? Like it sounds like there's a way to kind of find somewhere in the middle that helps to bridge that gap. I do have a question about that though. Like a lot of these individuals that are coming over to work, if we're looking in the data and in the demographics, a lot of these individuals are not ones that have been highly educated to the point that maybe you and I are, and that health literacy might be a bit of a kind of a mix. How do you kind of bridge that, or maybe parse out the difference between this is a health literacy issue with this patient or this is a translation issue with that patient? How do you find you can kind of balance deciding which one you need to work with there?
That is the lack of health literacy, or at least westernized health literacy, is a major theme in my work with Indigenous patients. But then for the most part, you know that it's that rather than language barrier, because most people I work with speak English as a first language, except for some of the elders. I'm laughing because I think that probably what is helpful in that setting is using Fife, which is hilarious because I think some of us rolled our eyes when we were learning Fife in medical school. Everything has to be an acronym, but I think that there is something really important about like eliciting people's ideas and understandings about a topic, because you will realize sort of what they're taking away from what you said. Having a good translator can be helpful. Like sometimes you need a little back and forth with the translator, like, okay, this is what I'm trying to get from them. Like, can you help me communicate that? And they can sometimes then, instead of just verbatim translating for me, they might be able to express it in a slightly different way. And then trying to figure out like what those gaps are. And whether it's a gap in understanding, or sometimes it's just a difference in the medical system. Like it might be that their doctor, when they were growing up, or when they go back in the winter, does things a certain way. So they might find it a little bit strange or disconcerting that I'm not doing it that way. And they might worry that I'm missing something. So I think trying to understand like what their feelings are, maybe where that's coming from. Like, oh, is there a reason that you think that I should be doing X? And then you realize it's because that's what's been done for them before. Establishing that can be really helpful to sort of getting to a place of mutual understanding.
That's super cool. I think it's hilarious that Fife kind of comes up, because I think we're especially like at least in my circle, we definitely are kind of clowning around with it, but it's nice that it really shows up in good ways. I find it super interesting when you're talking about having to really have that discussion of what do you see it as, and what do you view this body part or whatever, because I think that has a lot of connection to some previous episodes and some themes that we've talked about on this show, where with trans care specifically, like when you are asking these individuals, what do you call this body part, or what's the way that you'd like to be referred, or anything like that, like if you're just learning how to move into this different cultural space to be able to provide care, it sounds like those are the types of questions that you have to ask. You have to know what these individuals view it as and what they give labels for, and then you get into a better space than just having to kind of spout information at them.
Absolutely. It helps you avoid making assumptions.
Seems like the positive, to try to avoid assumptions. That's what my gym teacher always told me, so it's nice that it kind of pops up all the time.
Yes.
Well, Mary, thanks so much. It really means a lot that you kind of came to speak with us today. And I think there's a lot of really great insight that learners could take away from this episode, and especially about just getting into that community feel and just understanding that what you see out there is stuff that you need to adapt yourself to, and continue to be a learner into the future, even though we kind of think that maybe our learning might be done when residency's over, when medical school's over. And it's really just reassuring to hear that migrant farm workers are getting care from somebody like you. I think it really is a huge positive that somebody that cares as much is really at the helm of a lot of this stuff.
Thank you. And it's nice to chat with you, because I think as a learner, you bring so much insight into the system that I think, even I'm only 3 years into practice, but you start to just accept things as the status quo. Whereas I think learners are more willing to challenge things and to ask questions about why it is the way it is. And I think that like fostering that spirit through your podcast is a very worthwhile endeavor.
Sweet. It sounds, yeah, it means a lot, and great. Really happy to hear there's a whole team that's working on a lot of these episodes. And I think if any listeners are here and are really interested in keeping up with these topics, then the opportunity is here, right? So that's awesome. Well, thanks so much, Mary. It really means a lot. And hopefully we'll get to chat with you soon. And hopefully maybe there's some learners who are inspired in this episode to come and help out with you, or just get involved in migrant farm worker care in general.
Yeah, I'm always happy to have learners at my clinic. They're on Sundays in Langley, and also happy to take learners up north with me. There's funding through the Rural Education Action Plan for that. So always happy to have people with me.
Sweet. Both sound like awesome opportunities. So hopefully someone will take you up on it. It means a lot. Well, thanks again. Thanks so much for joining us.
Thanks.
Thanks for tuning in to Just Medicine.